Good afternoon, everyone. Thank you for joining us. This is our second in our series of four CEO, CFO topical webinars that we'll be offering throughout this summer. Today's topic is one that we've heard often, and it is a growing concern of our rural providers. Zach is going to be presenting over Medicare Advantage, the analysis and strategies for critical access hospitals. We are a smaller group today, so feel free to unmute your lines, put something in the chat. I'll be watching the chat. If you're watching this recording and have any questions at all, please do not hesitate to reach out. And with that said, Zach, I will turn it over to you.
Thanks, Laura, and good afternoon, everyone. It's nice to be with you. As Laura said, we're going to be talking about Medicare Advantage, and that's a really hot button topic these days. So first off, we're going to talk a little bit about what Medicare Advantage is and how it differs from traditional Medicare on the cost and coverage side of things. Next, we'll talk about how Medicare Advantage has grown at an increasingly growing pace over the past several years and what some of the reasons are for that. And then talk about what are some of the consequences and some of the issues that certainly as providers we're all dealing with on a daily basis. Next, we'll talk about and go over a case study analysis that Wintergreen performed for a client where they had suspected, like many of you, I'm sure, that they were getting underpaid by Medicare Advantage in comparison to Medicare. So we did an analysis for them to try to quantify what that looked like so they could then use as leverage for informing MA payers, renegotiating with payers, and even to the extent of getting some of their elected representatives involved with some of the issues that they're encountering. And then lastly, we'll finish up on some of the best practices and things that we can do to try to make up some of the shortfalls and combat the issues that we have with Medicare Advantage. So first, again, we'll go over this kind of quickly, but just like a brief overview of Medicare Advantage. It is an alternative to traditional Medicare that is generally offered by private insurers. So think of your United Healthcares, your Humanas of the world that are approved Medicare plans. So it covers everything that Part A and Part B cover. So you got your hospital stays, doctor visits, tests, and other treatments. Medicare Advantage can also have some additional benefits, though, that Medicare itself, traditional, doesn't have. Some of those things include vision coverage, hearing, dental, prescription drug coverage, and then some more unique type of things such as gym membership discounts, over-the-counter medication discounts, transportation. I've even heard of where plans will have an increase to the Social Security amount monthly for patients. So a lot of different things like that. Oftentimes, many plans offer a $0 premium on top of the Part B premium, but beneficiaries may still encounter unexpected costs in the form of high copays and deductibles and things that they're often not thinking about when they're trying to make a decision to transfer to a Medicare Advantage plan. Additionally, there's other Medicare Advantage plan limitations, such as having smaller networks of providers, or they may find that no provider they've seen for many years is not out of network. And so lack of coverage, and then sometimes incurring higher costs as well in that process. So in terms of coverage, Medicare Advantage plans cover all medically necessary services that traditional Medicare covers. As I said, there's some certain extra benefits that they may have. In terms of Medicare, beneficiaries can have a separate Medicare drug plan, so that's Medicare Part D. Oftentimes, Medicare Advantage plans will have this Part D benefit included in their plans. So they can't really join a separate Medicare drug plan. And then oftentimes, too, for traditional Medicare, that there's a biggie here is that they don't need prior approval to cover services under traditional Medicare. And as we all know, oftentimes, and with, I would say, increasing frequency, that for a Medicare Advantage plans, beneficiaries need to get prior approval for certain services. In terms of cost, traditional Medicare, and again, for Part B services, the beneficiaries need to pay 20% of the Medicare approved amount or in the case of us as critical access hospitals, that's 20% of the charges after meeting the deductible. For Medicare Advantage plans, it varies from plan to plan. Sometimes it's higher, sometimes it's lower, but they also have an additional premium. For Medicare, beneficiaries pay a monthly premium. Um, and again, if they decide to have Part B, there will be an additional premium for that Part D coverage. And then for Medicare Advantage, beneficiaries pay the premium and may also have to pay the plan premium as well. In terms of limitations on coverage for traditional Medicare, there is no yearly limit on what beneficiaries will pay out of pocket unless they have some type of supplemental coverage, such as a Medigap plan. And one of the things I think draws patients to Medicare Advantage plans is that they often do have a yearly limit capping the amount of out of pocket costs. So, from that perspective, it may seem more attractive to a lot of beneficiaries. And as I mentioned kind of in the previous line, that for traditional Medicare, beneficiaries can buy a Medigap policy to help fill in some of those gaps, where Medicare Advantage beneficiaries cannot buy Medigap. That's a little bit about the coverage and the cost. Next, we'll talk a little bit more about the growth or proliferation of Medicare Advantage plans. So, as we can see by the charts here on the left, that there's about 60 million total Medicare beneficiaries as of last year. And for the first time, more than half of all of those enrollees are involved in a Medicare Advantage plan. So you can see to the right as well that we've seen the numbers of Medicare Advantage beneficiaries grow significantly and really starting to go, almost kind of parabolic as time has gone on. And we've seen that meteoric rise in Medicare Advantage. I'm sure many of you are seeing that as well in the communities in which you serve. So, really, how do we get here, and why has this growth been so meteoric? And some of the answers include that certain celebrities have been pitch men or pitch women for Medicare Advantage plans, and so kind of appealing to some of the Medicare age celebrities. So we got Joe Namath here, one that I see all the time, where he's talking about all the great things that patients can get through Medicare Advantage plans. Additionally, having some of the services covered, such as dental and hearing and other programs that are easily marketed and kind of manipulated into the speak as they go out to seniors looking to decide between Medicare Advantage plans. Additionally, they've seen those benefits increase in recent years. So seniors are seeing that their benefits are increasing or that they're better than Medicare. And so beneficiaries will try to switch over to Medicare Advantage. And that's also continued to fuel Medicare Advantage plan growth. We've gotten to this point now, and certainly as providers, we've been the one that have been disproportionately suffering financially while Medicare Advantage plans continue to grow, continue to look at stock prices of some of the Unitas and Humanas and others. They continue to reach record highs. The benefits to seniors are increasing, but somebody's got to pay for that. And it's been us over the past several years. And a lot of that has to do with limiting payments to providers, prior authorization, some of the other things that we'll get into. And so what we're seeing is that hospitals and other providers are pulling back on accepting Medicare Advantage plans and seeing patients. And so this is creating, first of all, we're struggling financially, but it's creating access to care problems for patients. And ultimately, we'll be putting financial pressure on payers that will likely restrict future benefit increases as time goes on. So a little bit about how it's been going over the past few years. So the Medicare program has paid Medicare Advantage plans 6% more than if the plan enrollees were covered under regular Medicare. And that's according to a MedPAC report. And in 2023, that was about $27 billion more paid for Medicare Advantage plans than if the patients were enrolled just in traditional Medicare. So it's a more costly program than traditional Medicare. Additionally, last year, Becker's reported that there were 15 hospital and health systems nationwide that had dropped some or all of their Medicare Advantage contracts. And the most cited reasons for that was a significant amount of prior authorizations, denials, and slow payments from insurers. And we'll talk a little bit about that later on as well. Additionally, in January of this year, HFMA released a survey of 135 health system CFOs. And the main findings that, or things that I found were interesting in that report, is that 16% of the systems were planning to stop accepting one or more Medicare Advantage plans in the next couple of years. Another 45% on top of that said they were considering the same, but they'd never made a decision yet. And that 62% of those CFOs believe that collecting payments from Medicare Advantage plans is much more difficult than it was even a couple of years ago. And additionally, Medicare Advantage denials increased almost 56% for the average hospital in the period between January 2022 and July of 2023 per AMA or AHA and Centellus report. And the denials and inconsistent reimbursement led to a 28% in hospital cash reserves over that period. Certainly, it's been a very trying time over the past few years as these plans have grown and continuing to put additional financial pressure, either whether it be lagging payments or denying claims altogether, which is creating significant issues for us as providers. So some of the main bottlenecks of getting from the Medicare Advantage claim process through payment, as we said, have been prior authorizations, denials, and slow payments. And we'll talk a little bit about those things here. So first, on the prior authorization side, the intent of prior authorizations, or at least what they say the intent was that they were designed to help patients receive whatever the optimal care based on the evidence-based standards of the plans. But in reality, we know that this has been very different in that many Medicare Advantage payers are applying these prior authorization requirements in ways that are, one, delaying care, oftentimes for immediate and emergent services, that is leading to a lot of different things such as clinician burnout. It's driving up costs for us as providers because we need to hire additional staff, or we're spending an inordinate amount of time and resources trying to fight some of the denials and get our prior authorizations. And so really what we found is that it's really been used to deny medically necessary treatment for patients that would otherwise be covered by traditional Medicare. And they use these stringent standards that often have unreasonable levels of documentation and other requirements that we need to demonstrate the appropriateness of the clinical diagnosis. Next is denials and appeals. So as I mentioned above, really that we're forced into this very lengthy and resource intensive appeals process that oftentimes we just don't have the resources to go through. I mean, I work with a lot of hospitals and systems across the country, and they just don't have the bandwidth in order to continue to fight appeals or resubmit claims. And that's one of the ways that these MA plans are winning, in air quotes, the game, because they can go through this process of just denying large volumes of claims right up front, just deny them. And then it's up to the organization to then try to go collect on that and appeal them. And oftentimes we just don't have the ability to do that. And that's kind of corroborated with a report a couple years ago from the Health and Human Services, the OIG report, that said Medicare Advantage payers denied 13% of prior authorization requests that actually met Medicare coverage rules, and that they use clinical criteria that was not contained in Medicare coverage rules. So, for example, requiring an X-ray before approving more advanced imaging is an example, and just flat out denying services that were medically necessary. And the MA plans had said, well, some of the prior authorizations, they didn't have enough documentation to support medical necessity and approval. But after going back through all of the data, the report found that the existing record was sufficient to support medical necessity of services. And that additionally, for payment requests, that Medicare Advantage payers denied 18% of the of the payment request met Medicare coverage rules and the Medicare Advantage billing rules, and the payment was still denied. So again, 18%, that's pretty significant. That essentially almost one out of every five payment request is denied when actually met all of the existing criteria that we needed to meet. So continuing on with the denials and appeals, a report from a prior year or prior years earlier is that they found that 75% of prior authorization denials that were appealed were overturned. So again, it just kind of goes to show that there's widespread inappropriate denial of necessary services, and that just demonstrates that Medicare Advantage plans are saying, look, we're going to deny everything. And then if you want to fight it and appeal it, most of the time you're going to win, but you need to come and actually go through an additional step, an additional hurdle to try to get paid for the services that you are providing. Next is patient care delays. I mean, this is one that is, again, the money is one thing, but making sure that our patients are actually getting the care that they need when they need it. And that these prior authorization policies can oftentimes have a very negative impact on patient care received and outcomes for patients. And as Medicare Advantage enrollment continues to grow, these problems are going to continue to compound and will be jeopardizing patient health in the process. An additional bottleneck is the provider burden that we experience. So each plan has its own rules that we need to abide by in terms of prior authorizations, the appeals process, and there's often very little transparency around those things, or there's inefficient prior authorization submission methods, and again leads to a significant amount of burden and are very human resource intensive from our aspect, very costly as well, and we don't have oftentimes the staffing depth to be able to absorb those costs or be able to go through the processes and jump through the hurdles that we need to jump through. And so this documentation and prior authorization requirements are leading to key drivers of burnout, both in providers as well as just our administrative staff. And that's making the healthcare workforce shortages even worse. And that has its own wide ranging consequences for access to care. So CMS recognized, I think, after the last several years of seeing this problem continue to grow, that they needed to do something. And so with the calendar year 2024 Medicare Advantage rule, CMS enacted three main reforms in where they established that Medicare Advantage plans can't use medical necessity criteria that differs or conflicts with coverage rules used by traditional Medicare. They also established guardrails for identifying the limited instances in which the MA plans can utilize internal criteria to determine medical necessity. And basically, they said when a benefit is not fully established by Medicare, that the plan can show that the benefits of using the criteria are likely to outweigh any of the downsides, including access to treatment. And third, they required that MA plans have to establish a utilization management committee to review medical necessity programs, look at prior authorizations, and ensure compliance with the CMS coverage criteria. Now, all these things sound great, but without some of the monitoring and checking in on these MA plans, like for example, I think the last one could be particularly problematic because the MA plans themselves are responsible for the formation and administration of the utilization management committees. So I could see this being susceptible to abuse if it wasn't properly monitored, and almost kind of like the inmates are running the prison, so to speak, and making the rules. So something that it will be interesting to see how this changes or doesn't change in future years. It's good that CMS is noticing it's a problem, but I think there needs to be a lot of oversight in order to really see true change. So as I mentioned, we want to talk a little bit about a study that we performed of a financial impact analysis for a critical access hospital. So we were approached by one of our clients, and they they thought that they were struggling with Medicare Advantage collections, looking at that compared to Medicare, but didn't really know how to quantify it and what that looked like. And so they brought us in to take a look at that for them, and they wanted to understand, is there merit to the assertions that they're being underpaid by Medicare Advantage plans, and that's having a detrimental impact on reimbursements? And what are some of the things that are causing that, such as excessive prior authorizations, increased denials, slow payments, and then could we go through the process and quantify what that financial impact was and show like here's what if these Medicare Advantage plans, if these patients had traditional Medicare, what's the delta between the two? And so as a result, we did this analysis and we looked at what were collections as a percentage of charge, and we were able to quantify that across various financial classes. So, for example, we're talking about Medicare versus Medicare Advantage today, but we also looked at this for Medicaid versus Medicaid managed care. So the study went through a methodology of kind of how do we go about doing this? Because I recommend that everybody take a look at this and go through this process. But we looked at we pulled a bunch of data out of their EMR system to get all of the payer information. It had the charges, what the payments were, and we looked at this over it was fiscal year 2022. We're in the process of doing this for them again for 2023 as well. Next, we organized the data that we could then use to visualize that later on. So we created a crosswalk between all the different payer groups that weren't included in the original dump. So, for example, they lumped Medicare and Medicare Advantage. We needed to pull out what were all of the insurance classes that were Medicare Advantage and assign those an identifier. We also wanted to make sure that when we looked at charges and we looked at payments, as we pulled these reports, that they also tied roughly in line with what did the audited financials look like. So say we're for a data integrity perspective, to make sure that when we're running reports out of the EMR, that when we look at what they were actually paid and what they charge for different payers, that those things lined up with what the audited financials showed as well. And then we wanted to organize that in a way that would be able to be visualized and we could actually draw some conclusions out of. So, looking at the Medicare Advantage impact, so we have traditional Medicare on top, Medicare Advantage on the bottom. The light green on the left were the charges, and the darker green on the right are the payments of what was collected. So for traditional Medicare on 22.5 million of charges, they were paid $13 million for about 58% payment collection rate. And for Medicare Advantage on almost 18 million of charges, they were paid a little over $9 million, which was 51% of charges. So again, going through the analysis, we see that they in fact were underpaid by Medicare Advantage in comparison to where if those were traditional Medicare. It was a 7% difference, which worked out to $1.1 million for this organization. Now, I will say that this was what I would say kind of middle of the road size critical access hospital. But one of the things that was unique about them is that they're located near a military base and they have a very high TRICARE payer mix. So they have, in comparison to most critical access hospitals that are in the 35, 40, 50 upwards of Medicare concentration for payer mix, they're really more in the 25 to 30% Medicare payer mix. So I tell you that to say it was $1 million to them with a smaller concentration of this Medicare payer mix. Depending upon the size of your hospital, it could be smaller, could be larger, but just knowing that many of you may have a higher Medicare payer mix and thus this number could be larger as well. We wanted to take kind of a conservative approach here. But again, it just goes to show that based on what this organization was thinking was occurring, and then the numbers bear that out to show that they were underpaid by Medicare Advantage over the 2022 for them. So as I mentioned, we also did this for Medicaid and Medicaid managed care. And something that we weren't expecting was the delta to be even larger. So it The part that I wasn't surprised by is the lower payment rates. So 44% for traditional Medicaid, but 30% for Medicaid managed care. So this 14% differential is actually a $3.8 million impact for them. Now I know that the Medicaid managed contracts tend to be a little different in the sense of there's more negotiation involved where your Medicare Advantage contracts are supposed to be paying and following Medicare. That's not necessarily the case always with the Medicaid managed care plans, but it is a very significant difference for this organization. And it may also be very significant for you all watching this as well. So, again, I think it's important to go through this exercise to kind of just kick the tires on some of these things that we think are occurring, but we haven't really put numbers to. So next we'll talk a little bit about, okay, now we realize we have a problem. We've identified what that is from a numbers perspective, but what can we do about it? So we know that unlike our urban counterparts that are in more densely populated regions, we don't have the luxury of a large patient population that we can afford to turn away Medicare Advantage plans or patients. We know that these types of things would crush our inpatient census, would leave holes in our clinic schedules, reduce reliance on some of our ancillary services, ER utilization, all those different things. So we need to see Medicare Advantage patients. So what can we do about it? So we can acknowledge the problems and we can try to proactively address those relationships with payers directly and creating accountability with them, citing the specific rules and regulations and appeals. I've also found that working closely with your local payer reps and developing a relationship with them who likely they live in your town, they utilize your services, and I think appealing to them as, how do we create a more beneficial relationship will go a long way toward any future renegotiations and things with your contracts. Next is we got to know the rules of the payer's game, and we need to play by them. So we have the deck stacked against us. It's not fun. It's not easy, but if we at least know what the expectation is, it makes it a lot easier for us to then play by the rules of the game and get paid as we should be getting paid. Which then leads to the next thing of putting in the work and appealing the denials and doing this religiously. It's really important that when we're getting claims denied, that we're appealing them and we're showing why it's medical necessity and all those different things in order to make sure we get paid. I can't tell you the number of hospitals, and I'll use this hospital that I showed the analysis for, that they weren't doing a very good job at that, and they didn't realize what the dollar amounts were that they would get denied, and they wouldn't even follow up with an appeal. We got to do it. Additionally, we can try to pare down our Medicare Advantage contracts and partner with those that align best with our financial objectives. So basically, what are the good apples of the MA plans, and try to focus on working with them. Another thing we can do is invite competition into our service area. So I was working with a hospital where they had one or two MA plans, but they invited a bunch of other Medicare Advantage payers into their area. And really, the way they did that was trying to work with the main organization in scoping out the hospital's own health insurance plan. And they got them into the area. And when we introduced a little bit more competition, then we have more leverage to renegotiate contracts and some of the different language in there that may help us out from a reimbursement perspective. Additionally, we can do some community outreach. We can provide education to area residents, kind of informing them. I know you saw Joe Namath on TV and it sounds great, but here's some of the things that they're not telling you if you were to switch to a Medicare Advantage plan that you may lose. So try to combat the problem that way. In terms of the refusal to work with Medicare Advantage plans or to accept patients. We're a critical access hospital, and the majority of our cost structure is fixed, meaning that regardless of what our volume is, we're going to incur those costs. So, depending on the roughly 80 to 90 or more percent of costs are fixed. So, we're going to have the salaries and benefits and overhead and all that stuff that goes along with running a hospital. And by contrast, the variable cost is very little. And the variable cost is what is the cost to provide that one next unit of service, that next inpatient day, that next clinic visit. It's just these things such as patient food or medical supplies, medications, things like that. And so, since we're already incurring all of the costs and the variable cost for that next unit of service is very small, even if we have contracts with Medicare Advantage payers that aren't paying us, what they should in terms of Medicare, if we terminate those contracts, we would still be missing an opportunity to create marginal profitability. So, say Medicare pays us, $120 for something, and Medicare Advantage is only paying us $100. It might only cost us $10 or $15 to provide that service. So it's still marginal profitability contributing to the bottom line, even though it's not ideal. We just don't have the luxury of turning volume down. So this is something that we think about it truly from the economic perspective. We need to make sure that we're not refusing patients and working with contract or MA payers, because all volume is good volume. We just need to play by the rules and try to do the best that we can given the circumstances. Additionally, looking at a contract analysis. So, making sure that we put together a competent team to start evaluating our different payer contracts, making sure that we're able to locate the agreement, all the attachments, looking at the terms and the structure of our payer contracts, and developing a reimbursement strategy while engaging senior leadership in the process. And I think, a good step in that process is identifying a renegotiation priority matrix. And it's what is our worst contract, or what is our oldest contract, or what needs to be reviewed most, and then rank ordering those to kind of tick down a list of the different contracts that we need to review. We need to make sure that up front that we're willing to work through the entire process all the way through the conclusion, because it's going to be long and it's going to be difficult. And it's important that even after the fact, we're doing routine audits and looking at, here, what does the contract say we should get paid? What are we actually getting paid? Compare the underpayments, and then be going to the payers if we see those. Some of the things that we can do for quick wins is making sure that our Medicare rate sheets are going to our Medicare Advantage payers to pay updated rates. So again, if they're higher, that's certainly something we want to make sure we get it in their hands immediately to pay us at that new higher rate. If our rate sheet shows that our rates went down a little bit, maybe we want to hold that information until they ask for it to try to take advantage of the situation to the extent that we can. Additionally, looking at our contracts, as part of that process, making sure that all of our provider-based departments are paid as such. I've seen a lot of contracts where an organization will have rural health clinics, for example, and they're not being recognized as a provider-based rural health clinic, and they're not getting paid a rural health clinic all-inclusive rate. They're just getting paid a fee schedule. So making sure that all these things are loaded and that we're getting paid at the all-inclusive rate in that example. Next is creating a contract matrix. So this is something that we want to create, put in a place where it's easily searchable and findable, understanding what different payers are, when did we start the contract, where is the contract, where are all the amendments, looking at what are our rates, and put those in there, ratio cost to charge for our outpatient services. And then I even recommend adding things too, such as what are the prior authorizations that we need for some of the main services? What's that process like? What do we need to do? Also, if we need to file appeals, how long do we have to file appeals, and what is that process like? So we have all that information on hand, and it makes it easier for us to know what we should get paid, what does the agreement say, and if we need prior authorization and have to file appeals, we know what we need to do. I put the stat up here earlier about denials, but I wanted to highlight it again now that we're talking a little bit more about denial management. The denials increased by 56% for the average hospital between January 22 and July 23. And that led to a significant decline in cash reserves for hospitals. So this is a huge problem and is something that we need to tackle very carefully. And that starts with within the organization breaking down silos and making sure that we have the right people involved because we're going to need some uh, communication and work between our clinical team and our finance team in order to do this well. Additionally, we want to make sure that we're identifying the root causes of denials and figure out why they're happening. Maybe we have policy and process issues causing it. I'll say that data is king, and I highly recommend creating a denials management dashboard. So there's a little clip off to the right here. This is something that we have helped clients put together, but it's a way to track all the different denials that they have. Look at what is the count of denials by month, what is the denial amount versus what is the amount recouped in certain months, understanding denials by category. So maybe it was denied because of medical necessity, maybe it was a coding issue, maybe it was a duplicate claim. Try to understand why all these things are happening so that way we can find trends and figure out if it's a specific service or a specific provider or 81% of our denials are for this specific reason. And it's going to allow us to shine light on the areas that we need to mark for improvement. Additionally, establishing denials management protocols. So, knowing the Medicare Advantage payer rules and playing by them. And again, creating that grid, identifying the specific rules for each plan is going to make it a lot easier for us going through this process. And then once we've created a denials dashboard, we've started to work through this process that we want to quantify and understand what is the magnitude of the revenue impacts. So this may be something where we want to look at a dollar amount and start with denial codes for certain reasons that have the highest dollar value, or maybe it's the easiest thing to take down and we just want to pursue that. But having some type of process and reason for why we're going through the process and being able to start fighting these denials and just changing the way that we've been tracking and monitoring and appealing these in the past. So maybe we want to look at a denials management department. And I know that almost kind of sounds silly, we're small critical access hospitals, but this is something that a lot of the big systems do. And I know that we don't have the resources, but at the same time, what is it costing us to not have a person or people looking at denials and being able to fight them? It's a lot. And so whether we have that function done by case management or coding or have, a nurse that does appeals or a physician leader, these are things that we should be thinking about. I've even seen hospitals and systems institute denials management in provider contracts because they know that there's a lot of money tied up there and they're paying providers to be proactive in fighting their own denials. Making sure that we have coding routinely meeting with providers and ensuring that documentation matches that the services are performed and that all those claims are being coded appropriately. And then, lastly, just pretty straightforward that a lack of effort to appeals denials is the leading cause of not getting paid. And as I said, a large percentage of denials are not resubmitted and they're not fought for. And as we saw by the results of the OIG reports, that those high denial rates have a really high overturn rate. So if the Medicare Advantage plans are denying everything, we need to go in and appeal those, and we have a really good chance of overturning those in time. And then some other considerations, doing our peer-to-peers. So if they deny claims, go through that peer-to-peer process, and oftentimes we'll get that overturned. When we're looking at our medical documentation to support it, make sure that we're painting an accurate picture of what the patient needed to, say, justify an acute admission and document what the treatment plan for the patient will be like during the stay. Additionally, learn from appropriate denials. So it's really learning from our mistakes. Figure out why the documentation was inadequate for that acute claim and that it should have been observation, and understand and learn the rules of each plan and fix that going forward. Also, plan ahead for prior authorizations. So, unlike many other provider insurance interactions, prior authorization requests have a direct and significant impact on patient care. So we should be monitoring prior authorization response times to make sure that the patient has timely access to the services that they need. Knowing what needs to be done ahead of time and for which services. So before we order that MRI or total joint procedure, understand what are the prior authorization, what is the time involved there to make sure that patients are able to get the services they need when they need them and that we're able to get paid. So this really kind of shows like a summary of some of the last few slides as far as denial management. And so some final thoughts: don't go out and cancel your Medicare Advantage contracts or refuse to take your Medicare Advantage patients. Again, always remember that marginal revenue exceeds variable cost. And even if they're not following Medicare the way that they should be, we're still generating positive margin from accepting those patients, making sure that we establish a multidisciplinary team and perform a deep dive into payer contracts, looking at the term and structure of the agreements and renegotiating them, making sure that provider-based services are recognized and paid as such, and that payments received mirror our contracted rates. Ensure that requirements for prior auths and appeals process are clear and understood by us as an organization, and that's going to reduce patient care delays and claim denials resulting in delayed or partial payments. Create a contract matrix that captures all the pertinent contract data in a single, readily available location that everybody on the contracting team has access to. And fight denials like your hospital's financial sustainability depends on it, because it does. And making sure that we're doing the peer to peers in order to overturn denials. And lastly, don't underestimate the importance of establishing rapport with payers. Like I said earlier in the presentation, starting at that local level and trying to appeal to them and explain situations of why this contract and the way that we're getting paid and the different prior authorization process and denials are affecting their local hospital and the providers in the area in which they live. It's much easier to appeal to them than appeal to, the CEO of United Health, a faceless organization. So we need to start small and try to build from there. Any questions?
Hi, Zach. Thank you for sharing a great presentation, but also a list of ways or tips and ways to counteract. I was just curious if anyone on the call has anything to add to that you found that was successful or somewhat successful.
And has anyone gone through that process of trying to understand like what the delta is in between what you should be getting paid and what you are? I saw something actually earlier this week, and I meant to say it in the presentation, but it just jogged my memory. Is there was a hospital in Arkansas that the CEO had gone through this process, and it was really kind of like a public thing that he had put out on a publication that I read, where it was really the same thing that we did for this client. And I think that's something really important for organizations to do and really understand what that is, because then it gives you leverage and bargaining power with payers. And again, you can use that with some of your elected officials to say, look, this hospital is not always going to be here unless we're getting paid fairly. We're doing all the work that we should be doing. We're treating patients. It's medically necessary services that we're providing, but they're not paying us. And we're small, and it's tough for us to negotiate against, the Uniteds of the world. So we need help.
Hey, Zach.
Oh, go ahead.
Hi.
Sorry. Hey, this is Josh Tucker. Hey, at Preferred Management. We do that exercise for our Medicare Advantage for our inpatient swing bed claims because that's kind of the lower hanging fruit, if you will.
Hmm.
So we do that. We look at those every one of those claims that come through the door to see if we're being paid correctly. And unfortunately, even if sending in a rate letter with our claim sometimes doesn't get the claim paid right. So, one of my questions for you is I appreciate the last slide about building rapport with the payers, but the problem is, and as everybody on this phone can attest to, you call United and you're going to get somebody in a cubicle 500 miles away that is going to answer the phone. So you're not going to really build any rapport with client with a payer contact. Do you have any recommendations on how we can kind of work with payers to, and I don't know if we need to ask for a certain person when we call on the line, or can we be assigned a representative, but is there somebody that we could work with at the Aetnas and the Uniteds and those plans that we actually have a point person that can kind of help us with the ins and outs of the claim instead of just being at the mercy of the 800 number and it's a big beast and we're not.
Yeah, it's a good question, and I guess that I would try to ask for somebody locally. I mean, most places have teams all over the place. Like you're right that there's a call center in a big city somewhere that you're not talking to somebody locally, but try to get to somebody locally or just continue to develop a relationship with, if you don't find someone locally, to try to develop a relationship with someone that you're able to speak with, whether you're representative, even if, they're not living in your community, again, building rapport, telling your story to try to help effectuate change from a contract perspective.
That's some of what I was going to say too. Finding that representative has been our biggest challenge. And also like just diving into what they're paying and what they're not paying. Just as an FYI for the other facilities, what we've mainly ran into is our rural health clinic AIR rate. And it's, yeah, they're paying us like half of what they should be paying us there. And then whenever we are billing our professional fees on our UB claim as method two, they sneak it in there and they don't deny it. They just completely write it off. So I just happened by it. I went in there to see like what are they paying us, and that's how I ended up catching it. But had I not just gone back just to do an audit, I would have never saw it. They would have just wrote it off. So that's another thing that they try to pull the wool over your eyes a little bit. Um, and I haven't been able to succeed yet. But last week I was told that there was a small rural hospital in Missouri, and that CFO got the Medicare guidelines and sent them a pretty strong letter that said, "You pay me this, or I'm turning you into CMS," and they wrote him a check. So I know that I think they just try to see how hard we're going to fight. But if we do contact them and strong with them, I do know that they will make it up.
Yeah, that's the majority of the game and not uncommon. And that was, doing that audit, I think is very important. That was something that at my hospital before I got in consulting was a big eye opener because they will try to just underpay you. And if you don't realize it, then you don't know. You just assume you can't, you have to be your own advocate and confirm that what contracted rates are they're actually paying you. And if they're not, it needs to be brought to their attention.
Hi, Zach. We had some comments in the chat. Ray had a few comments. How are they getting around that for publication without activating the disparagement clause of these contracts? Some of these MCR and MCD Advantage plans will not let them separate from the commercial contracts. And then also the Oklahoma State MCD program is attached to SHOP funding, the way the legislation is written.
So as far as the publication I was referencing, it wasn't specific numbers or specific plans in any sort of way, but it was just again trying to shine light on we are getting underpaid as this small critical access hospital and we need to do something about it. And whether that is, a lot of other hospitals do a similar exercise. Like for example, if all the Oklahoma CAs were to go through a process and say, hey, collectively, we're losing $80 million from Medicare Advantage plans, that's something that I think would spur some action on the Oklahoma legislature more than just to say ABC Hospital is losing $1.1 million from Medicare Advantage plans. So I think it's really more part of like a larger discussion and getting the word out there. Hey, we know we're all struggling with this and we're being taken advantage of. But if we start talking about it and everybody kind of chime in on a lot of the problems that they're experiencing, that only then can we start to effectuate change. I appreciate the comments and questions.
And then Kenna also had a comment. I'm looking forward to checking our MA rates compared to traditional Medicare with the analysis. Thank you so much for sharing. I'm very concerned about the current Medicaid transition. We are in that process as well, moving to manage Medicaid here in the state. Are there any other comments or questions that folks might have? All right. Well, if you get off of this call and you go, oh, I wish I would have asked that, please let me know. I will get in touch with Zach. Or if you're watching this recording and you have a question, please let me know. I'm happy to reach out to Zach, and we're the greater cohort here. So please do not hesitate to reach out. Thank you again for your time, Zach. And thank you all, and have a great day.
Thank you all for the opportunity, and great to present to you again and catch up with Laura.